Of course, Dr. Bharti was supposed to speak on managing complications of phakic IOL. But since I think he has laryngitis and his voice, he cannot be heard. So Dr. Bupesh will be giving this talk for him.
So thank you, Dr. Sri Ganesh. And I think you have covered almost all the complications and wonderfully managed complications. So I'll be just enumerating some of more complications of ICL. So first thing is that after ICL, you may need using glasses for near if you're above 40, or if there is undercorrection, then you need glasses for distance also. So in cases of residual refractive error, bioptics is a good option to cover those residual errors. We can go for the PRK or LASIK after doing ICLs also. So that is a good option for managing the residual refractive error. ICL exchange is another option. If there is too much of disparity in the outcome, then you can exchange the ICL and put the correct ICL. In cases of high vault, the oversized ICLs not completely in sulcus, and sometimes OVD is behind the ICL. So you have to look for them. If there's high OVD, more OVD in the behind the ICL, the pressure will be high. So you need to remove it. If it is too oversized, as Dr. Sri Ganesh told, that you can rotate it vertically. And if it is not managing with that also, then you need to explant and put the new ICL of proper size. B-scan, OCT, and UBM helps a lot for seeing the vault and the position and the sizing of the ICL. And high vault causes glaucoma. So previous designs used to do iridotomy, but with the newer designs, you don't need to do iridotomy. And sometimes there is a retained visco. So AC wash is very important during the procedure. So make sure that there is no viscoelastic remnant behind the lens or in the antechamber. The AC has to be clear, and then close the eye. And in case of low vault, the main problem is the undersized ICL, and it can cause anterior subcapsular cataract. So we have to be very careful while sizing the ICL, and low vault can cause anterior subcapsular cataract. So we need to follow up these patients and how it is progressing. And if you think that there is any sign of anterior subcapsular cataract, it's best to exchange that lens. And as Dr. Sri Ganesh told, that axis rotation works very well for the non-toric, but with the toric, it's difficult to rotate. You cannot rotate it, so you have to exchange it. So these are some of the complications like glaucoma. If the ICL is oversized or isn't correctly positioned, it can increase the pressure in the eye. Vision loss if high pressure lasts long. Early cataracts, blurry vision, cloudy cornea, retinal detachment, some sort of intraoperative infections, or you need additional surgery. So proper preoperative workup is very important. Detailed retina examination, sealing the weak areas of the retina, looking for the cataract status. Don't miss any pre-existing cataract or opacities in the lens. So we should avoid ICLs in those cases. And pressure management is very important. So we have seen that pressure rise is common after the ICL surgery. So always check the pressure in every visit and see how it is going. And always look for the vault clinically on the slit lamp. And if you think that it's too high or too big, always take the help of ASOCT or UBM. And once the lens is inside the eye, repositioning or removal of the IOL may be required if the lens is at the risk of damaging any intraocular structure, iris, or the lens. And the presence of cataract, history of any RD or serious retinal disease has to be taken care before, and patient has to be explained about its pre-existing diseases. Many patients have high myopia, so they have pathological myopia or amblyopia, or the perceptive visual acuity is not that great. So patient should know what is going to achieve after ICL. And these are some of the serious complications that you can encounter after ICL, although the rates are very low, like endophthalmitis, TAS, ocular hypertension, accidental anterior capsule rupture, trauma, ICL dislocation, and retinal detachment. And these are the list of most common complications that we encountered, like TAS, ENDOF, ICL subluxation after blunt trauma, focal anterior cataract, large wart or small wart, and corneal edema. So we should always look for the health of the endothelium also before planning the ICL surgeries. Thank you.
Thank you, Dr. Bupesh.
Thank you, ma'am.
That was an exhaustive and a scary list.
Yeah.
But
it is.
Having said that, I would say that today's day and age, where you have the most advanced ICLs, also better technique to measure and instrumentation to handle the ICLs, the
Yeah. It is
complication
reduced,
rate
yeah,
has reduced
significantly,
drastically,
yeah.
and it is coming out to be also a procedure of choice for
Choice.
those cases where you can't safely go on the cornea.
Yeah,
So your refractive patients do have alternatives
ma'am.
in terms of ICL.
Thank you, ma'am.
Right, sir? Anything else?
Thank you, ma'am.
So it was really a good presentation. Thank